Hello guys, let me know my voice is audible or not. Good. So now we are going to start our live program. That is, hey guys, hello future doctors, how are you all? So welcome back to MedSteps YouTube channel. So myself, I am Anandjana, final year medical student. Okay. So now we are in day day 4 of our first week general surgery series. Our live topic today we are going to discuss about acute abdomen overview. Then after we are going to discuss about appendicitis. This is very high yield topic in see this topic. NEET, PG or PLAB, like our university exam, our clinical rotation exams. This is the topic is very high yield topic. Okay. So then after how we have to do clinical assessment and like from top to bottom, from basic to clinicals, everything step by step we are going to discuss in this video. Okay, so without time waste, let's start our live 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 studying. So this live stream will be for 3 hours. The 3 hours divided into three parts. Each part will be like 1 hour. In that 1 hour, we can see like three seasons. Okay, so in one season, I'm for like total these things I'm following like Pomodoro method. Pomodoro method study method means it's like 50 minutes you have to you have to read or you have to study. Then after 10 minutes you can take break. Like that we are going to do three seasons, three breaks. Okay. So without time waste, if you are studying with me, grab your books and try to take some bottle of water. Then after just mute your the distractions like phone and everything. Okay, keep your material ready and let's start with me. Let's study together. Okay, so without time waste, let's start our season 1. So guys, we successfully completed our season 1. Okay, now we will take 10 minutes break. After that, we will start our season 2. Okay, in season 3, we are going to discuss about appendicitis and the abdominal overview. Okay, so let's take break for 10 minutes. You can stretch yourself, you can hydrate yourself, and if you want to eat something, you can eat. Okay, then after we will continue our studying. Okay, so let's take 10 minutes break. So guys, 10 minutes break then. So let's start season 2. Okay, so 15 minutes we are going to read. Then after 10 minutes we will take break. Then after 15 minutes we are going to start our live discussion. Okay, so stay tuned with me and we can continue our chapter. If we have any doubts, we will discuss in our live discussion. And drop one message what topic we are going to reading now. Okay, preparing now. Okay, so let's start season 2. 50 minutes. So guys, we successfully completed our season 2. Okay, so let's take 10 minutes break. Then after we are going to discuss about appendicitis and little anatomy, embryology, histology, physiology, everything. Okay, so without time waste, let's take 10 minutes break. Then after we are going to start our lifestyle. Okay, so if you have any doubts, you can drop one message in live chat. So based on that, based on the topic, we will discuss. Okay, so let's take 10 minutes break. So guys, let's start our season 3. Now we are going to start our live discussion. Okay, so today our topic is appendicitis. Let me check my voice is audible or not. Good. So let's start. Appendicitis. This is most pathological condition we can see in our medical field. Okay, so before knowing the pathological condition, we have to know the embryology, how the structure is formed, when the structure is going to develop, what week, everything we will discuss. Then after we will discuss some anatomy, then after pathophysiology, okay, then after the clinical features, then after silent symptoms, then after management, diagnosis, and the complications, like pre-operative complications and post-operative complications, and what are the surgical methods we have. Everything step by step we are going to discuss in this video. Okay, so let's start. First of all, what is appendix? Appendix means, for example, yeah, you can see this image here. Here you are seeing here, this is the embryological appendix part. Okay, so here what happening, here we can see one loop. That loop we call jejunal loop. Okay, so here we have one duct. The duct we call Vitalian duct. This one, this Vitalian duct, when it's coming to, we can see some bud. Okay, this is the bud. Then in bud we can see one Vitalian duct. That Vitalian duct, when it's coming to sixth week, in that sixth week we can see the embryological development. It will form appendix. Okay, so that bud means that is cecum. Then below the cecum you can see one duct, that is Vitalian duct. When it's coming to sixth week, in that sixth week you can see it will form like this cecum. Okay, in down of the cecum or below the cecum you can see appendix. Okay, you can see that appendix, this is ileum, and this is the cecum. So from ileocecal junction, we call this part ileocecal junction. Below the ileocecal junction, exactly 2 centimeters below, we can see appendix. Okay, this is appendix. This appendix is attached with tinea. Okay, so this is the main. So now, if anyone asking you like, tell me about appendix, then you have to tell appendix is a one of the narrow worm-like structure. Okay, worm-like structure or finger-like structure also we can tell. So this appendix we called vestigial organ or vermiform appendix also we can call this thing. Okay, or you can call this like end. You can see one type of ending tube, okay, and it's arising from posterior medial wall of the cecum, where you can see this thing posterior wall surface of the cecum, okay, this posterior medial wall surface of the cecum, and you can see approximately 2 centimeters below of the iliocecal junction, okay, below of the iliocecal junction you can see appendix. Now graphs anatomy, where exactly you can see that location means exactly you can see this location in you can see in right lower quadrant region. This is left lower quadrant region, this is right lower quadrant region. First of all, that abdomen we can divide into 4 parts, okay, that is upper left lower quadrant region and right lower quadrant region, right upper quadrant region, left upper quadrant region, okay. So here you can see that this is right lower quadrant region. In right lower quadrant region you can see the appendix part and cecum and everything, okay. So here you can see one point, that point we call McBurney point. How you can find McBurney point means we have one bone, that bone we call the ASIS, means anterior superior iliac spine. So 1 by 3 from anterior superior iliac spine, you can see, you can form one imaginary line. In that imaginary line, if you're seeing like 1 by 3 from ASIS, except that point is McBurney point. So why this point is important means based on this point only we can easily find out the that appendix. Okay, so that's why this point is very important, McBurney point. We can see the length of the appendix, like it will, that length will be like 6 to 10 centimeters, okay, and sometimes it varies from 2 to 20 centimeters, okay. So that location I told is like terminal end of cecum, where 3 tenial joints about like 2 centimeters below the iliocecal junction or iliocecal orifice. You can see the diameter. If you're seeing that appendix, for example, this is cecum, okay. In this cecum, here you can see iliocecal junction. Here you can see one finger-like structures like this, okay, that is appendix. Okay, so this appendix, if I'm cutting like this, if you're seeing inside, the diameter will be like 3 to 8 mm. Okay, the size of the lumen inside the, we have one lumen, that lumen if you're seeing means that lumen will be like 1 to 3 mm, like max thick size. Okay, that luminal capacity will be like less than 1 mm. So then after when you are going to see the appendix part, in this appendix you can see some types. We have some various positions of the appendix, okay. So yeah, this is the various types of positions of the appendix. Total most important positions I'm going to tell, that is 4. First one, retrocecal. Retrocecal is the most common appendix part, okay. So if you're seeing this retrocecal part, you can see this retrocecal appendix, you can see behind the cecum, and 95 percentage, 65 percentage, and 65 percentage, you can see 65 percentage of human beings. In human beings, you can see this type of retrocecal appendix, okay. Next one, subcecal. This subcecal, that means we can see this is below the cecum. 2% of people this type of subcecal appendix we can see. Next one, pelvic one. This is pelvic one. Mostly 31% of people we will get, we can see this type of pelvic type appendix. Okay, why we are telling this pelvic means it's hanging over the pelvic brim. This is the pelvic brim, right? In pelvis you can see 2 lines, that is we call pelvic brim. So this appendix is attaching near to we can see the pelvic vein. That's why we call that is pelvic appendix. Okay, 31% of people we can see this thing. Next one, pre-ileal, pre-ileal or this one, pre-ileal or retroileal. We can see this thing like 1% of appendix is behind in front of the ileum. You can see. Okay, this is the various position of the appendix. So based on we have some tests. Based on the test, we can easily understand without opening. We can easily find out which position that appendix is there. Okay, so we will discuss the thing from when we are going to deep in this topic. Okay, so this is the positions of the appendix. So next, blood supply. So if you're seeing like arteries, in artery blood supply you can see appendicular artery. This appendicular artery branch of iliocecal artery. The iliocecal artery arising from superior mesenteric artery. Okay, this is step by step. Okay, so superior mesenteric artery is branch of abdominal aorta. Okay, abdominal aorta. So this is the step by step. So this is I told about we discussed about arteries. Now we are discussing about veins. That is appendicular vein, branch of ileocolic vein, branch of superior mesenteric vein, branch of portal vein. Okay. So if any patient have appendicitis, it can lead to portal pyonia or it can lead to liver abscess also. Okay. So that's why this is very important. And some people, if any person getting appendicitis means they are very prone to get peritonitis, liver abscess, and these things. Why? We will discuss when we are discussing that time. I will tell you why. Okay. Next one, lymphatic drainage. In lymphatic drainage, you can see ileocolic lymph nodes, branch of superior mesenteric lymph nodes. Next one, nerve supply. In nerve supply is divided into two parts. One is sympathetic, and another one parasympathetic. In sympathetic, you can see lesser splanchnic nerve, that is T10. Okay. In this T10 dermatome level, we can see lesser splanchnic nerve, uh, where you can see this thing exactly in umbilicus. So that's why if any patient getting about appendix pain means you can see visceral pain in peri-umbilical region. Okay, then after it will shift into right lower quadrant, but first the pain will start from para-umbilical region because that is the main sympathetic lesser splanchnic innervation is there. That's why. Okay. Next one, parasympathetic nervous system. In parasympathetic nervous system, we can see motor and secretory like vagus nerve. Okay, so this is the things is very important in anatomically. Okay, so these are the gross anatomy. Now, in appendix, we have one important point that is mesoappendix. Okay, this mesoappendix means it's like one of the extension of the mesentery. Okay, this is extension from the mesentery. It's like it contains appendicular artery like like branch of ileocolic artery and derived from superior mesenteric artery. Okay, and what are from this mesoappendix? I told some arteries is there, right? The arteries will end till that appendix. Okay, that means the arteries will provide blood and it will end to appendix. So this area is very prone to get thrombosis. Because of the thrombosis, that vessels will get gangrene. So because of that, it can lead to appendicitis. Okay, so this is the main thing. This is like um, pathological condition. Why? How this condition is coming? Okay. So next one, we discussed the emotions. Then after histology, if you are if you are if you are doing like cross section of the appendix, you can see some layers. First one, mucosa. First one, epithelium. In mucosa, you can see epithelium. Then after we can see lamina propria. Then after muscularis mucosa. Then after main thing is submucosa. why I'm focusing in submucosa means the submucosa have many lymph nodes, lymph follicles. So if any infection is there, in any infection came to um, appendix, then what will happen, that appendix will get enlarged and it will cause total obstruction. Because of that obstruction, because of the lymph node vesicles, lymph node hyperplasia, the submucosal will get swollen and it can lead to block the lumen, and it can lead to appendicitis. Okay, so that's why this submucosal layer is very important. Okay, after submucosa, you can see muscularis propria. Muscularis propria means you can see some muscles. In that muscles like inner circular muscle, outer longitudinal muscle, then after finally you can see serosa. So this is the histology parts of the um, appendix. Okay, so we discussed about embryology, we discussed about class anatomy, we discussed histology. Okay, now what is vestigial organ? Vestigial organ means it's like waste organ, like that. Many people are telling, but vestigial organ means this appendix will help for immune, because it can secrete immunoglobulin Ia, mean IgA. This appendix can secrete IgA. Okay, so now acute appendicitis. So what is appendicitis means? Inflammation of the vermiform appendix is known as appendicitis. Usually, why this thing happening? Because of due to obstruction. Because of that obstruction, that infection or inflammation, you can see. After that infection, inflammation, when it's going to severe, it can lead to perforation, and it can lead to peritonitis. Okay, so this is the step-by-step approach about appendicitis. So now, most commonly, this appendicitis we can see in young people, then after secondary to elder people. Okay, why we are saying means, mostly if any person is not eating like 5 rich diet, they are very prone to get this problem, because um, I told we have ileocecal junction here. Below the ileocecal junction, you can see, below the 2 centimeters, you can see vermiform appendix like this. So whenever that food is coming, automatically it have to go to anti-gravity. If that food is it will form some colloid structures like seed type, ball type. It will form, and it will go to appendix part. If it's going to appendix part means, then only it will cause obstruction. Then after it can lead to infection. Okay, so this is the main thing. Then after seasonal variations like May and August, like uh, appendicitis also we can see in many young people. Now causes. What are the causes? Most commonly you can say means, first one, like causes will be like unclear, but maybe because of diet, because of decreased fiber rich diet, and this thing most common in Western countries people. Okay, because always they are consuming the baking bread and these things. Okay, if they are eating fiber rich food, maybe they will not get these things. Okay, so that's why the causes will be like idiopathic, means unknown cause. So now we are going to discuss about main causes, that is obstruction of the lumen. How? Because of picalip. Picalip means hardened stool, like small thin ball of stool will accumulate in the lumen of the appendix. Most commonly we can see this thing in adults. Then after the obstruction, then after we can see swelling, gangrene, perforation. Okay, this is step by step. Next one, like strictures, tumor, gallstones, foreign body. Okay, um, lymphoid hyperplasia, common in young adults, and foreign bodies like seeds and worms, uh, like round worms, thread worms. Uh, in worms, we can see like ascaris, lumbricoids. Okay, in pinworm, we can see like oxurius and vermicularis and adhesions, and the king like carcinoma in cecum. Okay, near the base, and ileocecal like Crohn's disease. So these are the things can cause obstruction to appendix, and it can lead to appendicitis. Next, we are going to discuss about infection, like viral infection. The viral infection is associated with like mucosal edema and inflammation with like lymphoid hyperplasia. This is bacterial infection. Okay, what are the bacteria can cause this type of things conditions means E. coli. Like E. coli will be like 80 percentage of things E. coli can cause. Then after enterococci, 30 percentage, and streptococci, anaerobic streptococci, Clostridium welchii, and bacteriolosis. So these are the things very prone to cause this type of things. And viral gastroenteritis also can cause lymphoid tissue swellings, leading to obstruction. Okay, so these are the main thing. And some people will get pseudo appendicitis also. Pseudo appendicitis means it's like um, inflammation in ileum, but it can mimic like appendicitis because of Yersinia infection. Okay, and if any patient have Crohn's disease, that Crohn's disease also will mimic like appendicitis. So we have to know how we can how you can diagnose the appendicitis. If you know this thing properly, you can differentiate the problems also. Okay, so next one, next we are going to see the um, risk factors. In risk factors, age will be like 10 to 30 years old is the main age. Okay, and some people like from birth to till 2 years they will get, but very rare. Okay, then 5 to 35 years. This is the very risk factor of the risk factor of to get appendicitis. Next one, low fiber diet and family history, male gender, and seasonal variations. We already discussed that is the risk factors. Okay. Next one, pathophysiology. In pathophysiology, we can divide into two types. First one, obstructive pathogenesis. Second one, non-obstructive pathogenesis. So first, I'm going to discuss about obstructive pathogenesis. Here, what's happening here? Somehow that luminal getting obstruction because of fecal. Fecal means the fecal matter is obstructing in that lumen, or maybe seed. Maybe some child without knowing he swallowed the seed, then after it's stuck in in the appendix. Okay, so these are the things can cause luminal obstruction. Whenever that luminal obstruction is there, then after that body will lead that one that appendix will leads to increased mucus production and inflammation. Okay, so this appendiceal mucus can obstruct. Then the fluid will collect into the lumen, and we can see that the lumen will get distant, and inside the lumen we can see increased intraluminal pressure. Then after we can see the bacteria, and we can see the blockage of venous lymphatic drainage is a blockage, and in that lumen we can see that the bacteria will get multiplying. Okay, then infection, the capillary venules and vascular congestion. Okay, and you can see then after impaired blood supply, because of impaired blood supply we can see mucosal ischemia, then after it can lead to ulceration, then after bacteria translocation, then finally we can see um, it will spread from mucosa, then after submucosa, from after submucosa we can see like gangrene, perforation, then after that perforation we can see in tip of the appendix or base of the cecum. So these are the parts will get that whenever that appendix getting swelling automatic, um, that appendix can get burst, or maybe that, that inflammation, that pus, that fluid, that secretions, everything will come out. Okay, so this is the obstructive pathogenesis. Next we can see the non-obstructive pathogenesis. This is like acute inflammation with mucous membrane with secondary infection without obstruction, like it causes non-obstructive appendicitis, like may lead to resolution, fibrosis, recurrent appendicitis, obstructive appendicitis, and gangrene, peritonitis, okay, and suppression. So these are the things. Now, clinical features. What are the things we can see when patients have appendicitis? In clinical features, first of all, abdominal pain. So I told before the pain will be like first we can see peri-umbilical region, then after it will shift to right lumbar, right lower quadrant. Okay, so here most commonly we have some signs. I will discuss about the signs later. Then after we can see anorexia. In anorexia means loss of appetite. This is most common cause. Then after nausea and vomiting. Then after low grade fever and diarrhea and constipation. Constipation will be rare, but you can see this. Okay, so these are the clinical features of um, appendicitis. But here for appendicitis we have one triad we called Murphy triad. Don't confuse with Murphy sign. Murphy sign will be for acute cholecystitis. One is pain. Pain will be in periumbilical region, then after lead to right lower quadrant region, then after nausea and vomiting, then after temperature, fever will increase and elevated uh, WBC. Okay, so these are the main things, three things you can say in Murphy triad. Okay, if Murphy triad is everything is positive means you have to suspect that the patient have appendicitis. Okay, next. Next, we have some signs that is first one tachycardia, mild pyrexia, tongue flood, appendicular abscess, and abdominal tenderness with cough and facial expressions you can see. But here we have total 5 signs. These 5 signs is very important. First one, McBurney sign. If we are touching, if we are asking to palpate the right lower quadrant region, like from umbilicus to ASIS, 1 by 3 from ASIS to umbilicus. If you're seeing 1 by 3 point, if you're palpating there, the patient will feel pain. So that pain is the patient is getting with that McBurney point is positive. Then after you can see rousing signs. Rousing sign means if you're palpating in left side, the patient will get pain in um, right side. Okay, so this sign we call rousing sign. Next one we have one sign that is Blumberg sign. Blumberg sign means rebound tenderness. We have to press hard and we have to take out. Then the patient will feel like soft like pain. Okay, so whenever the patient is getting like that pain, that Blumberg, that appendicitis is positive. Next one is Soyer's sign. In Soyer's sign, we have to uh, bend the knee into 98 degrees. We have to move. Whenever you are moving like that, the patient, the appendix will get it will irritate, so it will cause pain. So if you are feeling the thing, we have to suspect that patient have retrocecal appendix, because in retrocecal appendix only, if you the Soyer's sign will get first. Okay, next one, obturator sign. In obturator sign, we have to rotate internally. We have to rotate internally to the knee. Whenever you are rotating internally, that time the patient will feel the pain. That means the patient appendix will be in pelvic part. What I told before, the pelvic in pelvic position we have one appendix, that is that in the 31% of people you can say that that pelvic appendix. So why we are calling that is pelvic appendix means it's very close to pelvic brain. Okay, so next one we can see guarding and rebound tenderness because of irritation or perforation. Okay, so how we can investigate this thing? We can do blood test. In blood test like CBC or complete blood count, the WBC will increase greater than 10,000 millimeter cube neutrophils and dominants, and increases CRP, C-reactive protein also. You will see the increase in thing. Okay, then after urinary analysis. In urinary analysis, if like mild WBC, if appendix is near the ureter. Okay, so because of the thing, you can say mild pyrexia also. Then after, if like no bacteria, then it will help to rule out urinary tract infection. Okay, next one, imaging. In another thing, next thing is imaging. In imaging, X-ray is better thing, because in X-ray while doing abdomen you can see picalit or ileocolit or appendocolit, and if any, you can rule out the any other pathological condition like intestinal obstruction, uterocolit. Okay, these are things you can easily rule out by X-ray. Okay, then after in chest, you can see ectopic pregnancy. Okay, so usually you can rule out with beta HCG. Okay, for differential diagnosis. Next one, we can do ultrasound. If patient like ultrasound will help for sensitivity like 85%, specificity like 92% for diagnosis. Okay, now what are the things you can observe in ultrasound means enlarge is greater than 6 mm, and we can see hyperechoic thickened appendix wall like greater than 2 mm and target sign, and appendiceal wall thickening, appendicolit. Okay, and the introduction of submucosal continuity and periappendicular fluid and non-compressible appendix. Okay, for ruling out some gynecological pathologies, you can check like ureterostones, pancreatitis, ovarian cyst, ectopic pregnancy, and for confirmation of the appendicular mass and or abscess. Okay, or you can do CT scan also. In the CT scan, we can see like CT scan is the gold standard investigation test for adults. What are the things you can observe here means enlarged appendix greater than 6 mm, wall thickening, fat stranding, and abscess or perforating signs. Okay, so this is the CT for CT scan. Okay, next, differential diagnosis of appendicitis. We have one mnemonic that is salpingitis. SALPINGITIS. This is salpingitis. S means small bowel obstruction. A means acute gastroenteritis. L means lithiasis like renal colic or ureteric stone. Next one, P. P means pelvic inflammatory disease. I means ileoceliac disease or ileocecal tuberculosis. N means nephritis or pyelonephritis. And G means gynecological causes like ectopic pregnancy, ovarian torsion, and ruptured ovarian cyst. I means inflammatory bowel disease like Crohn's disease. And P means syphilitis means neutropenic colitis, intercession, and sigmoid diverticulitis. So these are the differential diagnosis of appendicitis. Next, we are going to discuss about management. First one, every time, whenever you are trying to do management, always follow primary assessment, that is A, B, C, D, E. Airway, breathing, circulation, okay, any disability, any exposure. After this thing, you can go with pre-operative management. In pre-operative management, okay, if you have to do nil per orifice means nil by mouth, okay, no food or no drink, and we can start intravenous fluids and like intravenous antibiotics like ceftriaxone with metronidazole for perforated cases, and we can start analgesia like we have to avoid NSAIDs because NSAIDs can cause risk of perforation. Okay, so that's why we have to avoid the NSAIDs. Next one, we have some surgical treatment procedures, that is first one laparoscopic, another one open appendectomy. In laparoscopic appendectomy is preferred because of it will take less time staying in hospital, and very less pain and very fewer wound infections. Okay. Next one, open appendectomy. For open appendectomy, we have to follow McBurney's incision or Lynch point open peritoneum. Okay. This is like first we have to first we have to do McBurney's incision. Then after we have to uh, start lunge point. Then after we have to open peritoneum and we have to identify the appendix, and we have to divide the mesoappendix, and we have to ligate the appendix arteries. Then after we have to ligate the base of the appendix, and we have to remove the appendix. Okay, we have to remove out. Then after we have to do irrigation. Then after we have to close the peritoneum and we have to suture the wound. So this is the step-by-step of the surgery in simple method. Next, you can see post-operative care. In post-operative care, intravenous antibiotics for 24 to 48 hours, and we have to start early mobilization because we can risk of for DVT and these things, and wound care, and we can have to start diet, start off our fluids within 12 to 24 hours. Complications we can see like the perforation, peritonitis, and sepsis, abscess formation, wound infection. Most common problem is after appendix. Most common we can see surgical site infection. Okay, or ileus, bowel paralysis, and stump appendicitis. Okay, so this is the main thing. Now, so in appendix, we discussed about management, complications, surgery methods, clinical features, pathophysiology, sign and symptoms. Okay, and we discussed some amount of histology, glass anatomy. Okay, and normal about abdomen. Okay, so everything we discussed about appendicitis. Okay, same to same like this we are going to discuss in every day except Sunday. Okay, because Sunday I have to go church and I have to do many things. Okay, so these are the things we are going to follow. If you have any doubts, you can ask me in comment section, and every time same time we are going to visit. We are going. I'm going to start this live stream. Okay, so every time you will get one notification. So whenever if you are seeing, if you are watching this thing live stream, if you are studying with me, be be regular and always what are the topic I'm giving. So try to complete that topic because we took 3 weeks for general surgery. In this 3 weeks, we are going to do we are going to cover every topic about general surgeries. Okay, so try to be with me and follow the guidance, and you will get good benefit. Okay, in exams and everything. So what are the like here? What are the things I'm discussing? Everything I observed in my general surgery department. Okay, and I got some information from my doctors. Based on that, I'm going to discuss in this live discussion. Okay, so we will meet in our tomorrow live stream. Okay, so if you have any doubts, you can contact with me with Instagram, or you can drop some message in comment section like that. Okay, so thank you for being with me. So take care. Bye bye. Have a nice day.